Hi everyone, my name is Sarah Sims and we're really happy that you could all join us today for the lecture in Volume 5 of our 12-week No Neuropsychology Didactic Series. And that brings you lectures from experts in the field covering different topics each week. So this series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. We would really like to thank everyone in the committee and our sponsors for their financial support of the series. You can also find us on YouTube, so please like and subscribe to see all the videos that are posted each week. Before we start, we want to make everyone aware of our YouTube channel, and also here are our disclaimers for the series. So this training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube later this week. All right, so now it's my pleasure to introduce Dr. Elaine Mahoney today for our talk on stroke basics. So Dr. Mahoney received her PhD in clinical psychology from University of Wisconsin-Milwaukee in 2018. She also has an MS in clinical psychology from the University of Wisconsin-Milwaukee and a BA in psychology and cognitive sciences from Rice University. She completed a pre-doctoral internship in clinical psychology and a postdoctoral fellowship in neuropsychology at the James A. Haley Veterans Hospital in Tampa, Florida. Dr. Mahoney's clinical practice includes the assessment and treatment of adults with traumatic brain injury, stroke, and brain tumors. And her research has focused on the ongoing rehabilitation needs of individuals living with chronic sequelae of traumatic brain injury. So thank you for joining us, Dr. Mahoney. Go ahead and take it away.
Let me go ahead and share my screen. You can see that? We're all good? I'm going to assume we're good. So as Sarah said, I'm Elaine. I am a neuropsychologist at UAB Spain Rehab. I work as an inpatient neuropsychologist with patients who are days, weeks, months out from a stroke, a traumatic brain injury, a brain tumor, and pretty much anything else that can happen with the brain that needs rehab. So stroke is a favorite population of mine because you get to see all the things you learn in your neuroanatomy classes, all the things you learn in your neuropsych classes in a really strong and impressive way. And you really get to help these patients kind of get back to their life after going through something that's been really stressful. So today we're going to take it back to basics and talk about different types of strokes, the kinds of neuropsych presentations you would see with different strokes. And then we'll spend a little bit of time talking about what recovery looks like and what outcomes are after stroke. Okay, so my objectives today, just what I talked about, we're going to talk about types of strokes, neuropsych presentations, and outcomes. Okay, so I said we're talking about basics. We're going to start really basic. So what is a stroke? I think this is a term that gets thrown around colloquially, and our patients often have heard of people who have had strokes, but getting down to what classifies as a stroke. And this was the definition I came across that I think kind of captures the idea the best. And so it's a sudden onset of impairment in some sort of neurologic functioning that's due to a severe decrease of blood supply to the brain. And the different types of strokes are different ways that blood supply gets decreased. But this is kind of the overarching idea of what a stroke is. For some reason, the flow of blood to the brain has been decreased, and that causes all kinds of different impairments. You may see different terms when you're learning about stroke. So cerebrovascular accident, or CVA, is probably the second most common after stroke. You may also hear cerebral infarct or infarction. And then you don't see this too much in kind of the scientific literature, but sometimes on patient handouts, they'll call it a brain attack. So that's something to be aware of, is another term that people use for stroke sometimes. Okay, so there are two main types of stroke: an ischemic stroke that you can see on the left of this diagram, and a hemorrhagic stroke that you can see on the right. We're also going to talk briefly about something called a transient ischemic attack, or a TIA. But let's start with ischemic stroke. So ischemic stroke is the most common type of stroke in adults. So about 87% of all adult strokes are ischemic in nature. And an ischemic stroke occurs when there's a blockage of a blood vessel that prevents blood from continuing to flow through that vessel. So you can see in this picture here at the top, let me get a laser pointer for you. There's some sort of blockage in this artery, and therefore you lose blood flow originates at the site of the occlusion. So most commonly what this is you get some fatty plaque buildup on the inside of your artery. And then either it kind of bleeds and there's a blood clot formed right there, or it pinches off that artery completely. And again, therefore blood can no longer flow through that artery. You can also have an embolus, which is a fatty plaque or a blood clot or some sort of little clot that travels through your circulatory system from somewhere else in your body and ends up in your brain and blocking an artery in the brain. So a lot of times you can have what's called like a cardioembolic stroke, which means that a clot from your heart traveled through your circulatory system up to your brain, causing a stroke. But it can really come from anywhere in the body when we're talking about an embolus. It doesn't really make a difference if you have a thrombus or an embolus for what it's going to do to your brain. Again, that blockage is really the key component of an ischemic stroke. And again, it's blocking that blood from continuing to flow through the artery and perfusing the parts of the brain that require those nutrients, that oxygen, and everything that it takes to keep the neurons functioning. So the reasons that you might have an ischemic stroke. So we already kind of talked about that fatty buildup of plaque in your arteries. That's known as atherosclerosis. And so this comes from poor diet, from genetic causes, and it kind of narrows those arteries so that either you can have a thrombus form or you just have a narrower artery, which means an embolus is more likely to get stuck, right? We all know that cardiovascular, cerebrovascular health is really important for preventing stroke. So this includes conditions like hypertension, high cholesterol, diabetes, obstructive sleep apnea. Any of these conditions put you at higher risk of having an ischemic stroke. And then another thing that's kind of interesting that people don't often think about with stroke is anytime you have a surgery or you suffer a trauma, you're at higher risk of stroke. So a lot of the patients that we see that have strokes when they're younger, it comes from this surgical or traumatic cause. So when you have, say, a heart surgery, your heart can throw some clots that can end up in your brain, leading to an ischemic stroke. When you break some of your long bones, like your femur, it's common for a fatty kind of plaque, a fatty embolus to break off, and that can also end up in an ischemic stroke. So that's kind of a lesser thought of and a less common way of ending up with an ischemic stroke, but it definitely still does happen, and especially in that younger population. Ischemic strokes can be kind of hard to see on CTs right at the beginning because, again, all we're seeing is, this brain tissue that's no longer getting blood, and it takes some time for that to have an impact. Not very much time. Without blood, brain tissue starts to die within about 5 minutes. But again, that doesn't show up on CT often when patients are admitted to the ER. It's not uncommon to have a CT scan that looks fairly normal. However, in the following days, the evidence of that ischemic stroke will become very clear on CT. So you can see within 24 hours here in this right hemisphere, you're starting to lose gray-white matter differentiation. And by 2 days after, you can see this damaged tissue in the right hemisphere. So what does having a clot and ischemic stroke do to your brain? So the primary injury is that, like I said, when brain tissue isn't getting blood, oxygen, energy, the tissue dies. And that's kind of the primary injury that happens in an ischemic stroke. So you can see in this bottom picture here, the direct tissue that artery perfuses dies off. Those neurons die off. There's also an area around that dead tissue known as the penumbra, which is kind of at-risk tissue. So this tissue, if there isn't blood flow coming from other arteries, if we don't reestablish the patient's blood flow, there's a possibility that this tissue will also die. And kind of that's the focus of the initial intervention, is making sure we preserve as much of that penumbra to keep functioning as high as possible. After you've had the stroke and that tissue has died because of the lack of oxygen and blood, there's also risk for secondary injury. So vasospasm is something that can happen after kind of a clot has passed. And this is basically a constriction of your blood vessels, which unfortunately can lead to either another stroke or continued reduced blood flow and further damage to the brain. It's also possible for you to have a hemorrhagic transformation. So you can imagine when one blood vessel gets blocked off, the pressure in the other blood vessels can increase because the heart is still pumping the same amount of blood, but it can't go one way. So more blood is going to be pushed another way, which can lead to a rupture of another blood vessel and a bleed in the brain, which we'll talk about in a little bit. Whenever something happens to the brain, there's a risk for swelling or edema. And this is commonly seen when people have a stroke. And whenever you have swelling, there's only so much room inside the skull for the brain. And so we're at risk of the brain herniating or kind of pushing through the small openings in the skull. So all of these things kind of contribute to what the patient's deficits will look like once they make it to rehab, once they go home after having a stroke. A hemorrhagic stroke is a rarer phenomenon, but it still accounts for about 12% of adult strokes. And this occurs when there's a rupture in a blood vessel, and that results in bleeding in the brain tissue or in the meninges. So this can result in an intracerebral hemorrhage. So if a blood vessel bursts in the brain tissue, you're going to get blood kind of pouring out onto that brain tissue. It can also result in a subarachnoid hemorrhage. So our cerebral arteries go through the subarachnoid space over the surface of the brain. And therefore, if the blood vessel ruptures there, you're not going to get blood directly on brain tissue, but you're going to get pooling of blood in between the arachnoid matter and the pia mater outside of the brain. And both of these are bad for your brain and cause deficits. And we'll talk about how in a second. The main cause of a hemorrhagic stroke is hypertension. So that makes sense, right? If there's a lot of pressure on those arteries, they're more likely to rupture and result in a bleed. However, another cause for a hemorrhagic stroke is an aneurysm, which you can see down here. So an aneurysm is just a little outpouching of an artery. Unfortunately, the walls of an aneurysm are not as strong as the walls of your artery, and so they're more likely to rupture. And AVM is another malformation of your arteries that is more likely to bleed than your regular arteries. So both of those are factors that can cause a hemorrhagic stroke. Cerebral amyloid angiopathy is a condition where your arteries are kind of a little bit leaky and you get a lot of little bleeds, a lot of little hemorrhagic strokes that can cause, progressive deficits as you have more and more of these incidents. So unlike an ischemic stroke, a hemorrhagic stroke is really easily detected early on CT. And that's because new blood shows up bright white on a CT. So here on the left, we have an example of an intracerebral hemorrhage. You can see here in the right hemisphere, this is a pretty large one. And on the right here, we have an example of a subarachnoid hemorrhage. So there's blood in this subarachnoid space, which kind of fills in all those little crevices around the brain. So the primary injury for a hemorrhagic stroke, the brain tissue doesn't like blood being right on it. It's neurotoxic. So blood touching your brain tissue, like in an intracerebral hemorrhage, causes neuronal death. There's also reduced blood flow, right? Because imagine you have a hose and you stick a hole in the side of it and water starts pouring out there. There's going to be less water going through the end of the hose where you want it to go. And so, unfortunately, in addition to having all of this blood on the brain, more distal parts that are perfused by that artery are also getting reduced blood flow. There's also risk for secondary injuries here. So as blood fills some of the space inside the skull, there's less room for the brain, right? So we're going to have increased intracranial pressure and potentially herniation. So in this bottom diagram, you can see that when we have a hemorrhage here in this hemisphere, it's pushing brain tissue down and we're starting to experience herniation through the small opening down here. And so this is really dangerous because this pressure is putting pressure on the brainstem, which of course is very critical for us staying alive. So when we see this kind of herniation, this often calls for surgical intervention to relieve some of the pressure in the brain. And so we may take off a portion of the skull, and that gives room for this swelling and this pressure to be relieved in that direction instead of putting pressure on the brainstem. They may also have to go in and do something like clipping or coiling an aneurysm so that to stop that flow of blood into the brain. And unfortunately, whenever you do surgery on the head, you increase risk for seizures, you increase risk for infection, for further bleeds. And so these are all secondary injuries that can kind of increase the deficits that came from having this hemorrhagic stroke and cause more complications for the patients down the road. Okay, so I said we'd also talk about this transient ischemic attack. So this technically isn't a stroke. Sometimes it's called a mini stroke. And what it is, it's a period of stroke-like symptoms. So you may have weakness on one side of your body, you may have sensory loss or speech difficulties, but it goes away within 24 hours and it doesn't really leave a mark on your brain. So oftentimes this is just diagnosed because people have the symptoms and they resolve, but there's no real way for us to test if somebody's had one of these. So the most likely cause of a TIA is a thrombus that breaks up relatively quickly. So you can imagine you're having that kind of atherosclerosis that builds up inside your artery. It causes a blockage of your blood vessel, but the pressure of the blood breaks it up pretty quickly. Normal blood flow is restored and your symptoms go away. So you might think, great, it doesn't really matter. You know, it didn't cause any long-lasting difficulties. However, it's a warning sign. It's a warning sign that you've got some cerebrovascular difficulties that put you at high risk for having a stroke. And about a third of people who experience a TIA will go on to have a full stroke. And about half of those people will have a stroke within a year. So we really emphasize to our patients that these TIAs, while you're not having memory problems and you're not having weakness and you can still walk, it really is a warning sign that there needs to be serious action taken towards taking care of some of these risk factors like high blood pressure, like high cholesterol, through things like appropriate medication use, diet, and exercise. Okay, so moving on to the neuropsychological presentations, but before we do that, we have to talk a little bit about the vasculature of the brain. And I think this is an area that can be a little bit intimidating to trainees. There's so many arteries, they're hard to remember. And I think working with a stroke population really helps you to kind of learn this vasculature and learn how the brain receives blood from the circulatory system. So we're going to do a brief little review of it before we talk about different kinds of stroke presentations. So our brain receives blood from the heart in two ways. So blood gets pushed up the front of your neck in the internal carotid arteries and up through your spine in the vertebral arteries. So you have kind of two entry points into the brain through the neck. So those come up and form this circle of Willis that's on the inferior surface of your brain. So you've got your vertebral arteries coming up here, they come together and form the basilar artery. And off of that comes the feeding arteries to the brainstem, to the cerebellum. We'll talk about that in a little bit. You have and then in your circle of Willis, you have your posterior, your middle, and your anterior cerebral arteries. And these kind of take the whole surface of the brain and perfuse blood, giving it oxygen, giving it glucose, giving it all the things that the neurons need to function optimally. So when we think about different areas that are fed by those three main arteries, your middle cerebral artery actually perfuses most of the lateral surface of your brain. So all of this in red is perfused by the middle cerebral artery. The anterior cerebral artery perfuses the anterior portion of the medial surface of your brain. And the posterior cerebral artery, like its name, perfuses the posterior portion of your brain, but also your medial temporal lobe. So that's something that's really important to keep in mind when we're thinking about what makes sense in terms of cognitive deficits if you have a posterior cerebral artery stroke. Okay. I'm going to keep these pictures on each one because I know this is, again, a hard thing to learn. And so the more you kind of think through it, the clearer it becomes. So we're going to start with a middle cerebral artery stroke. And we're starting here because this is the most common type of stroke that you'll see. And that's because it perfuses the largest area of the brain. Most of the highest percentage of blood flows through the MCA. And so you're just most likely to have a stroke in some portion of your MCA. So again, we're talking about the lateral surface of your frontal, parietal, and temporal lobes. And if you can see on this side one, again, it's the lateral surface, but there's also some deep fibers into your basal ganglia. So with a middle cerebral artery stroke, an MCA stroke, these are kind of the things you're going to be looking for, thinking about if you see a patient you know has had this type of stroke. And to get all of these things, you would probably have to have a stroke right at the very beginning of the MCA. So that doesn't happen very commonly. And so when you think about a specific patient, they may have one portion of their MCA blocked off, and you may see a subset of these symptoms. But again, this is kind of the overall picture of what you should be thinking about for an MCA stroke. So the first is you're going to have contralateral motor weakness. So if you have a left MCA stroke, you're going to have motor weakness on the right side, right? And so it's going to be more apparent in the upper extremity compared to the lower extremity. So you're going to expect more arm weakness than you are leg weakness. And so let's think about that. We know that our motor strip has a homunculus, right? And the legs of the homunculus kind of tuck into that medial surface of the brain. And then the body kind of flips over down around the lateral surface. So it makes sense that if we have an MCA stroke, which affects the lateral surface of the brain, we're going to see more motor weakness in the arm than the leg, right? So that's kind of how you can reason your way through, using your knowledge of neuroanatomy, what you would expect to see from the patient in front of you. Similarly, we're going to expect to see contralateral hemisensory loss. Again, more in the arm than the leg. So they might have numbness, they might have tingling, they might have no sensation at all in their arm on the opposite side from where the stroke happened. You're also going to see contralateral facial droop. So this is a motor deficit, a motor and sensory deficit of the face. And again, this makes sense because the face is represented on the lateral surface of that motor and sensory strip. You might see a contralateral homogeneous hemianopsia, or in easier words to say, a field cut. So, and this is because you're damaging some of the fibers that kind of go from the eyes back to the posterior portion of the brain. So there's impairment there where you're going to get a deficit of vision to the contralateral side. And in addition to that, you get an ipsilateral gaze preference. So for example, if I have a left MCA stroke, I may not be able to see the right side of space, and therefore my gaze preference might be to the left side of space. So hopefully that makes sense. We're going to split the MCA strokes up into the left and the right hemisphere because they give you very different cognitive presentations. So if you have a left MCA stroke, we're hitting the language centers of the brain. And so here, this shows you the superior branch of the middle cerebral artery perfuses the left frontal lobe and Broca's area, right? Whereas the inferior branch of the MCA in the left hemisphere perfuses the left parietal and temporal lobes, hitting Wernicke's area. And so when you get a stroke to your left MCA, it's very likely that you're going to have some difficulties with either expressive language, receptive language, or both, depending on where in the MCA the stroke was. And so I'm sure a lot of you have seen this cookie theft picture before. This is one way that we can assess if someone has an aphasia, right? And so if you hit that superior branch of the MCA and get a Broca's aphasia, it may look something like this. You have a lot of non-fluency of speech. It's very difficult to express ideas. You have a lot of nouns and verbs, but not a lot of helping words. If you, on the other hand, hit the inferior part of your MCA, you're going to end up with more of a Wernicke's aphasia, where you can produce a whole lot of speech, but the comprehension piece is missing, and therefore it's not making a whole lot of sense. So these are just two examples, and I strongly, strongly encourage you on YouTube to go watch videos of patients who have either a Broca's or a Wernicke's aphasia, because it's really, it becomes a lot more clear what that speech pattern will sound like when you kind of see it in front of you. So when we hear left MCA stroke, aphasia is the number one thing that we're thinking of from a cognitive perspective. But we also might see something like apraxia. So the ability to do meaningful, purposeful movements with your limbs. So this is where we test, like, show me how you would make a peanut butter and jelly sandwich. Show me how you would salute. Show me how you would strike a match and blow it out. Things like that. And then a syndrome you can get with a left MCA stroke is Gerstmann syndrome. So this happens when you hit your left angular gyrus, and it's just kind of a conglomeration of a few different notable impairments. So that's right-left confusion, so not being able to tell your right from your left, finger agnosia, agraphia, and acalculia. And it's just kind of this weird conglomeration of symptoms you get if you hit that spot in your brain. And again, it's common to hit that, especially when you have an inferior division left MCA stroke. When we hit the right hemisphere, the right MCA, we get a very different cognitive profile. So the most notable thing you see with a right MCA stroke, especially if you hit the right parietal lobe, is a left sensory neglect. So this is commonly presented as a visual neglect. So for example, when I ask a patient to copy any of these pictures, you can see that they're neglecting details on the left side. So their right side looks pretty good, but the left side isn't complete. Sometimes they can get parts of it, drawing over from the right side, but they're definitely lacking in detail. You might think, okay, well, they just can't see it. But no, when you tell them to draw from their memory, they continue to neglect the left side of space. This isn't a visual problem at all. It's an attentional problem. So for them, when there is something competing on the right side of space, they will not and cannot pay attention to the left side of space. And so this is a visual issue in that you ask them to cross out every line on the page and they do not attend to anything on the left side. You put a plate of food in front of them, they get upset because it seems like it's a really small amount because they're only seeing what's on their right side. They're only attending to what's on their right side. But this really affects all your senses. So they might often neglect the left side of their body. Oftentimes when you go in and you see a patient with pretty significant left neglect, you'll find their left arm hanging from their wheelchair in a really uncomfortable looking position. And it's because they don't have attention to that left side. Hearing, if there's sounds on both sides, they'll neglect the sound on the left. tactile. They'll neglect the tactile sensation on the left. It's a fully attentional, it kind of crosses sensory modalities. So while we often look at it as a visual issue, just keep in mind that this is really a visual attentional and an attentional issue overall. One other thing that we commonly get with a right MCA stroke is anosognosia. So this is an unawareness of their deficits. So this is the patient, you go in the room and you ask them, okay, so like, what are you noticing since your stroke? And they say, actually, I'm pretty fine. I think I'm back at baseline. And they can't move half of their body. They have this profound neglect to one side. They may have some memory issues. They may have attentional. Their brain is telling them everything's okay. And that checking, monitoring piece of their brain has been damaged. So now they just kind of lack this overall awareness, which can be really difficult when we're trying to help them get better and they don't understand what problems they're having. You may also see communication changes when you have a right MCA stroke. So we often think of the left hemisphere as being language, but the right hemisphere is really important for prosody, for tone, for understanding the meaning behind language sometimes. And you may also see a lot of dysarthria. So that's kind of what a right MCA stroke would look like. All right, moving forward. So the anterior cerebral artery, remember here we're perfusing most of the lateral or the medial surface of the brain. So here we're going to have contralateral motor and sensory impairments, but now we're going to have greater impact on the lower extremity because remember the legs are hanging in that medial surface. You're also going to see some reemergence of some frontal reflexes. So these are things that you would see like in infants, but then they go away as you develop. But if you damage part of the frontal lobe, you may see reemergence of like a grasp reflex or like a rooting reflex or something like that. Because we are hitting a lot of the prefrontal cortex here, you're likely to see cognitively a lot of dysexecutive, inattentive, impulsive, perseverative, tangential, circumstantial, all of that behavior starting to come out. These patients might be inappropriate. They may lack inhibition. They may have really bad safety awareness, or they might go the other way and have really bad initiation and kind of just sit and not eat their lunch when it's brought unless somebody prompts them and just require a lot of prompting. When you get hit the left anterior cerebral artery, you might get some aphasia, like a transcortical aphasia, which looks like a Broca's or a Wernicke's, but you preserve repetition. And if you hit the right hemisphere ACA, you may still get some of that left neglect like we just talked about. So these are just some examples of some ACA strokes. You can see there's a lot of damage to the medial portion of the brain. All right. When we hit the posterior cerebral artery, not surprisingly, a lot of the deficits relate to vision and visual perceptual abilities. So here again, you might get a field cut, you might get full cortical blindness if you hit both sides. But then the thing we need to keep in mind as neuropsychologists is that the PCA does perfuse the medial temporal lobe. So when we're thinking about the cognitive profile here, we need to be thinking about memory impairment, right? Because we may hit the hippocampus here. But in addition to that, we may also experience some behavioral emotional symptoms. And that's because you're hitting that limbic system in the medial temporal lobe. So these patients might have like an exaggerated fear response. They may have a lot of paranoia that really get in the way with them recovering and interacting with their loved ones. So while we think of posterior as mostly being like a visual problem, we want to remember that the PCA perfuses the medial temporal lobes. And so we may expect to see some cognitive and behavioral deficits that come from that impact as well. One just little note here, if you hit the left PCA and you also hit the splenium of the corpus callosum, you might get a kind of rare syndrome of alexia without agraphia, which means that your patient can't read, but they can write. And so it can be really interesting. You can have them write a sentence for you and they can't read it back. They can write it perfectly fine. You take it away, you give it back to them, ask them to read what it says, and they can't read what they've written. And it's just kind of a disconnection syndrome. And it's just kind of a rare thing you get when you hit your left PCA and your splenium of your corpus callosum. All right, we can have strokes to our brainstem. Obviously, this is very problematic because your brainstem is required for you to stay alive and functioning correctly. So one interesting thing we would see as neuropsychologists with a brainstem stroke is you get kind of crossed motor and sensory findings. So you get contralateral weakness and sensory loss of your body, but you get ipsilateral of your face. And this is because the brainstem is where a lot of your cranial nerves come from. And so where they decussate, where they cross over is different from where your the nerves from your body cross over. And so you can get this interesting pattern where you have maybe left facial weakness, but right-sided body weakness. And that's really indicative of a stroke kind of at the brainstem region. You might also see eye movement abnormalities, dysarthria, so kind of slurred speech, dysphagia, difficulty swallowing, and at its worst, you may have what's called a locked-in syndrome. So this is kind of preservation of your cortex, so you can think, you can remember, but you've got complete loss of kind of motor. So you can't really engage with your environment, but you can still perceive and think and all of that. So again, at its worst, that's what a brainstem stroke can result in. And then finally, we have a cerebellar stroke. So we didn't talk about the arteries perfusing the cerebellum, but they come off of the basilar artery here in front of your brainstem, and they perfuse in a few different arteries around your cerebellum. When you have a cerebellar stroke, the main thing you're going to see is a lot of lack of coordination. So you might get ataxia, dysmetria, dysdiadochokinesia, which is a loss of rapid alternating movements. And basically, these people are just going to have difficulty kind of coordinating their motor functioning. They're also going to have things like dizziness, nausea, vomiting, headaches, double vision, nystagmus. It's perfused by a lot of the same areas as the brainstem. So you're going to get the dysarthria, the dysphagia, similarly to when you get a brainstem stroke. And while we think of the cerebellum as being really important for this motor coordination, it's important to keep in mind that the cerebellum does play a cognitive function as well. And so sometimes when you get a cerebellar stroke, you can get something called cerebellar cognitive affective syndrome. And this is basically just a grouping of symptoms, both cognitive and emotional, that result from cerebellar damage. The cognitive symptoms are usually dysexecutive, attentional deficits, sometimes a little bit of memory deficits, and the emotional symptoms are usually depressive symptoms. So you can kind of, while we think of it as being primarily a motor problem, keep in mind that with a cerebellar stroke, it would not be unexpected for you to see cognitive deficits as well. And then the last kind of neuropsych symptom I wanted to talk about is post-stroke depression. So depression is very common after stroke, and you may think, of course, they just had a stroke, so they're going to be adjusting to that and having some depressive symptoms, but it seems more than just that. So meta-analyses have reported about a third of stroke patients will develop post-stroke depressions in the 5 years following stroke. However, this paper here showed that the rates are actually likely higher when you consider kind of mild depressive symptoms. So that 1/3 really comes from meeting criteria for a major depressive disorder. The presence of post-stroke depression is related to poorer functional outcome and greater mortality. So it's something we really need to be on top of and aware that this is a fairly common occurrence after stroke. The etiology is, like I said, yeah, they just had a stroke, but there also seems to be very specific changes in brain chemistry that lead to depression more commonly after stroke than other types of head injuries. And it's been shown that while therapy and medication both help, medication actually seems to have the biggest impact on alleviating symptoms of post-stroke depression. All right, recovery from stroke. So I want to talk about outcomes, but it's very difficult because it's so varied from patient to patient, from stroke to stroke, from the brain they brought in before the stroke, from all the other things going on in their body and in their lives after their stroke. But in generalities, we can say that most patients with stroke will show a rapid recovery in the first 3 months post-stroke, with continued improvement seen across kind of 6 to 12 months, at which point it kind of plateaus. That doesn't mean that functionally patients can't see improvements after a year. It's just that the neural recovery portion is over. And now we're really working on figuring out the optimal compensatory strategies to improve their functioning in a day-to-day fashion. The final extent, how far they're going to get back, if they're going to get back to their baseline, if they're going to get 80% back, is really affected by a lot of different factors that we'll talk about. So these are kind of the positive prognostic factors. These are the things I'm thinking about when I'm trying to counsel my patients of, am I going to get better? How much better am I going to get? Am I going to have to live like this forever? So these are the things that are kind of good signs for me. So lower stroke severity. The NIHSS is a stroke scale that physicians will give like in the ED in the early stages of stroke that kind of goes through and ranks different areas of functioning. And this gives us kind of a severity score. So obviously a less severe stroke is a good sign in terms of prognosis. Similarly, if you have a smaller sized infarct on neuroimaging, if your stroke happens at the very end of a branch of the MCA versus, affecting more of the brain, that's going to be a good sign. Ischemic strokes tend to recover better than hemorrhagic strokes, likely due to all the complications that can come with increased intracranial pressure and the need for surgery and things like that with hemorrhagic strokes. Having fewer comorbid conditions is a good thing. So the patient that only has, one cerebrovascular condition versus all the cerebrovascular conditions is likely to do better as they recover. Younger age, having a younger brain to heal is a better thing. Higher SES, educational attainment, greater social support are all positive prognostic factors. And then being in a non-minoritized racial group. And this is a huge issue in most of healthcare, but especially in stroke, that minority individuals are more likely to have a stroke and they're more likely to have a poor outcome with stroke. And the reasons behind that is still something that's being researched. But I can say that they've shown that it's something beyond just SES, education, and social support. So this is something that needs to be a critical focus. And I think it's somewhere that neuropsychologists can play a great role in figuring out why we have such a disparity between different ethnic and racial groups. There's certain interventions we can do that put people at a better starting point for getting better after stroke. The biggest thing is if we can identify that someone's having a stroke quickly, there are things that can be done to break up the clot, to reestablish blood flow, and help them to have a less devastating stroke. So TPA is an enzyme that helps go in and kind of break up the stroke. And again, that means that blood can continue to flow to the brain. We're more likely to preserve a larger portion of that penumbra. And therefore, we're going to have less deficits from both a cognitive and a physical standpoint. The downside of this is you have to use it within 4 hours or it doesn't really work. And so it's really critical that we teach the community how to identify when someone's having a stroke so that they can get this intervention early. And that's why we've come up with all of these great acronyms here. So it started with the FAST, telling people to look for facial drooping, arm weakness, speech difficulty. And then there's been research that shows this doesn't really encompass all the symptoms that a patient might have from a stroke. So there's been 2 additional BFAST and FASTER, which incorporate kind of the balance, headache, dizziness, and then also of visual changes. So you can see taking into account more of those posterior strokes and cerebellar strokes, whereas FAST really is optimal for an MCA stroke. They can also go in and, break up that clot mechanically. Obviously, that's a more invasive procedure than just giving you some medication, but it really makes a difference. So this figure shows kind of the improvement seen from giving TPA within the first 3 hours after stroke. And so all of these patients, this is the percentage of patients that do better than those who haven't received TPA. Obviously, we're going to need to do that surgical intervention for hemorrhagic stroke. stroke rehab, what I do, and then afterwards, kind of those behavioral health interventions, helping people get to wear their CPAP, helping them figure out exercise routines that work for them and diet plans that are good for their health and for their brain, in preventing another stroke. That's what's going to really lead to, the best possible outcome. This is probably the slide I spent the longest on, which is funny because this is all it says. There are so many articles that say, 50% of people with stroke can't walk without a device, or in this sample, 47% had cognitive deficits at 5 years. And I struggle with that because, again, like I said, every single person brings a different brain into having a stroke. You can have a stroke at literally any portion of any artery in your brain that will cause different severity and different types of deficits. And so it's really hard to take a group of 200 stroke patients and make any sort of generalities about how they will recover. And so I'm going to leave it with stroke is a leading cause of long-term disability in the United States and in the world. And so it's really important that we, as neuropsychologists, work with community partners, work with physicians to help people learn the steps they can take to prevent stroke. So keeping yourself healthy from a cardiovascular perspective, help to have early identification when a stroke is happening so that you can get some of these reperfusion therapies, and then work with people who have had strokes to make sure that they stay healthy afterwards and that they learn all of the strategies they can learn to live functional lives despite the deficits that may persist from their stroke. All right, so there's my references. And now I'm going to open it up for questions.
Thank you so much, Dr. Mahoney. That was a great talk and great covering of all the basics of stroke. It was really helpful. We have a couple of questions. So we have the first one. What are the differences, if any, for strokes in pediatric patients?
So I am an adult neuropsychologist and therefore don't have a great broad understanding of pediatric stroke. But I do know that that strokes are not uncommon in kind of the perinatal period, and that children also do have strokes at time, although obviously to a lesser rate than the elderly population. Honestly, I'm not the best person to answer this question, but I will tell you that the Stuckey board review book has a great, they do a great coverage of both adult and pediatric stroke in their stroke chapter. So that's where I'd refer you as a starting point.
Yeah, thanks. It's really helpful to have good resources.
Yeah.
So another question is, what kind of post-stroke interventions are helpful? I know you already talked about prevention of stroke as a good way to make sure that you make things worse, but what sort of maybe specific interventions are good for maybe increasing functionality after stroke?
Yeah. So in the acute period, obviously we're trying to get people as much physical, occupational, and speech rehabilitation as we can. And the role we play as neuropsychologists in that is trying to figure out, first of all, in our assessment piece, what do those patients need? Where are the deficits? Where are the gaps? And then secondly, coming up with ways to ensure that participation is optimal, that strategy use is optimal. And so as an inpatient neuropsychologist, that's a large part of my role, is figuring out how to guide the team to best work with individual patients. Once we get out of acute rehab, patients will likely go on to continue to have physical therapy, speech therapy, but they may also need a lot of mental health and neuropsychological support here. So that's where we're really kind of trying to tackle that post-stroke depression, that adjustment to disability, and making sure that they are continuing to function and do things they enjoy and do things that are meaningful, because that only leads them to have a better long-term recovery. If we can figure out how to get the patient that loved to go fishing but now feels like, how am I going to do that when I need to use a walker? If we can help them problem solve and navigate that from, just a problem solving therapy, that can often have the biggest impact, even if, their need to use the walker doesn't change. And so I think a lot of times early on in the intervention portion, that we leave that to the people who know how to do that really well, and we just help guide them. I think later on, we have a very large role in helping figure out the quality of life piece.
Yeah, thank you. So another question is, how do you usually communicate to patients and their families issues surrounding recovery, and then patients experiencing chronic effects of stroke? So maybe they've had it several years ago, and past the bulk of their recovery.
Yeah. So, like I said, I work in an acute rehab. And so I think I get it a little bit easy in that I can kind of pass the buck and say, at this early stage, it's really hard for us to know what you're going to get back and what you're going to get back to, but we really just need to focus on the present moment. But I will tell you, I work with lots of people who are in the chronic phase. And my goal is kind of something I said here, is that sure, we are outside the window of your brain naturally recovering. If you can't move your leg in this direction at this point, maybe we're not going to be able to do that. But there's a lot of ways we can improve functioning even with these deficits. So say someone has chronic memory deficits, we can teach them the strategies, right? We can teach them to use the lists, to have the memory station, to keep a notebook, a memory journal, a pill box, all the things, right? So we figure out where are the areas that they're having difficulty functioning, and we help provide those strategies that they may not have thought of to improve their day-to-day independence. And so I come at it from this positive perspective of, okay, we're 3 years out. We know that things aren't just with time naturally going to get better. So we're going to have to take some action, right? We're going to have to figure out some solutions for this, and then kind of help guide them through that process and use our knowledge of those strategies to help find what works best for them.
Another question is, are there differences in post outcomes for the different stroke syndromes? So like maybe it was an MCA versus a PCA stroke. Is there differences in how their outcomes look?
I don't know that that's been, because again, there's so many. So it's very simplistic of me to say a left MCA stroke, right? So when you go into the medical record, you're going to see a left M1 segment, so even within an MCA stroke, that's such a diverse grouping. I will say that I know, so you're most likely to get, say, aphasia with an MCA, potentially an ACA stroke. And that does impact functioning to a severe level, right? If you can't communicate, that really impacts your quality of life and your ability to function at work and with your family and all of that. And so from observational, experience, I would say that those patients who have kind of those large MCA strokes are worse off than, say, a PCA stroke. But again, that's a large MCA stroke. You can also get a pretty tiny MCA stroke that only affects you motorically. So it's hard to speak in, and this is why I struggled so much with the outcomes, is it's hard to speak in generalities about stroke. It really is a kind of patient by patient, stroke by stroke thing.
Yeah, and like you said, it really helps you learn the vascular and
Yes.
neuroanatomy. Every patient is different, so you have to learn something new each time.
Exactly.
We also had a question. You mentioned depression in stroke patients, and so I was just wondering, is there any shared mechanisms between the vascular system and the depression that can occur with stroke, or is it more so just the functional decline related to depression?
Yeah, so my understanding of the research is that it's a little bit of both, but it seems to be a specific brain chemistry, kind of metabolic, neurotransmitter kind of thing that comes from having a stroke. And so it's not necessarily from the vasculature itself, but I think from the loss of neuronal tissue, the swelling and all of that causes changes in brain chemistry that lead to the syndrome known as post-stroke depression. And so, that might look a little bit different than just the adjustment to disability portion. And I think that that's why they believe that kind of antidepressant medication sometimes helps a little bit more than just therapy for these patients.
Great.
But it's a brain chemistry issue from my understanding.
Awesome, thank you. And then another question was, you mentioned that hemorrhagic strokes were typically poor outcomes. And so we're just wondering, what is the effects of the blood directly on brain tissue? Is that
getting really into the neurochemistry? Yeah. So my understanding of it is that just blood is neurotoxic to neurons. And so you're going to have cell death when that blood is directly on the brain tissue. And so that's going to happen in your intracerebral hemorrhages, right? You're going to have that blood directly on the brain tissue and kind of the death of those neurons. But a lot of hemorrhagic strokes are subarachnoid hemorrhages, because that's, again, where the arteries travel through before they kind of go into the brain tissue to perfuse. And so you get neuronal death from that as well, from pressure, from swelling, from compression of the brain against the skull. And so it's kind of both of those factors, both kind of the increased intracranial pressure along with the kind of direct chemical effects of blood touching brain tissue.
Great. I think that's all of our questions for today. So thank you.
These are great questions. And obviously there's a lot of research that you can do on your own into stroke. And it's a super interesting topic, and hopefully this gives you a jumping off point.
Yes, thank you so much. That was a great talk and a great covering of all the strokes basics. So thank you so much for that. And everyone, please join us again next week at 7 p.m. Eastern. We're going to be talking about culturally competent neuropsychological interviewing skills, building your toolkit. So we'll see you all then. Thank you so much.